Hello and good afternoon, everyone. My name is Melissa Williams, and I am the Director of Grassroots and Community Partnerships here at National Patient Advocate Foundation. You are tuning in to NPAF Policy Consortium. Shift happens, how rising costs are reshaping access to care and coverage. We know this title is a bit cheeky, and this is not a cheeky topic at all, but we're in for a really great discussion today, and I hope you're looking forward to it as much as I am. Before we jump in, I just need to make sure that we thank our sponsors for helping to make today's event happen. That is Bristol Myers Squibb, Johnson & Johnson, Lilly, and Vertex. And just some disclaimers. We have to acknowledge that opinions expressed by those not affiliated with us do not reflect our views here at NPAF. Nonetheless, we appreciate the opportunity to include different perspectives as part of today's discussion. So if you're no stranger to NPAF, or if you have seen any of our materials, you have seen our tagline that we are working to make the healthcare system work for all of us. The healthcare system should work for all of us. And we feel that a system that works for all of us includes physical health, mental health, in addition to financial health. These three things are just incredibly integrated. They cannot be disentangled. And we know that these three things are what are important priorities for people. Financial health dictates how people get care. And so that's what we're going to dive in today's discussion. We'll have this deep dive on how healthcare cost concerns drive people's decisions. And I want to just start, before I turn it over to our NPAF grassroots advocates to open with some of their lived experiences. We say that we want this that the healthcare system should work for all of us. But in preparing for today's discussion, my team went on their own deep dive on Reddit to see, is it working for all of us? And we grabbed just a couple of headlines. We understand that not many of you can actually read the fine print here, but you see the headlines. Is $2,750 a month normal for health insurance? Who's affording this? What's up with ACA credits? It goes on and on. So when we say that these policy shifts are impacting the lives of everyday people, we get it. These are kitchen table issues. These are discussions that are happening in households nationwide. And we feel it's important to have this discussion openly so patients do not feel alone or lost. So think of us today not on a virtual stage, but in your living room. This is a conversation that we think should be public, and we just are approaching it in that kind of way. And so I want to turn it over now to our NPAF grassroots advocates, our speakers who are really going to inject some reality to what we're going to be discussing here. I'm going to start with introducing Janet Marks. She is an NPAF volunteer who's been with us for only a couple of months now, but she's just someone that we've gotten to know really well just in the last couple months. And I think her story in particular really speaks to the impossible choices that patients everywhere are having to make. And so, Janet, I'm going to turn it over to you so you can start to share a little bit about what you've had to experience in the last couple of months.
Hi, everyone. I'll be honest, I'm a little nervous, so I brought some notes with me today. My name is Janet Marks, and I'm from Milford, Connecticut. I'm living with lupus, fibromyalgia, and Sjogren's. So I like to call myself a warrior. I'm also, as Melissa mentioned, a volunteer for the NPAF. I'm also a volunteer for the Lupus Foundation. Even though my insurance premiums increased gradually, when combined with the cost of my medications, it became too much. It may not have seemed like a huge amount to a lot of people, but it was to us, it was a tipping point. And also having to choose the best health plan that's offered for you due to your health situation. At the same time, I was also a caregiver for my parents who lived with us in an in-law apartment in our home, in which my father still resides. My mother was in hospice care in our home. She has since passed away a year and a week ago. I'm wearing this. It's called the Thumbie, and I'm wearing this and her name in honor of her. A few months after my mom's passing, my father developed bladder cancer. So while managing my own health, I was also helping my family through some very difficult moments. And the medical costs and financial pressure really became overwhelming. We were doing everything we could to squeak by, and that squeak became louder and louder and even turned into a bang. High insurance premiums, more prior authorizations, denials, etc. Eventually, myself and my husband and my father made the difficult decision to sell our home. We did not want to risk losing our house. We wanted to make sure we had money moving forward, like money for my father needs hearing aids right now, to have money for future costs. And I want to share that I did not go through this healthcare journey alone. I wanted to give back. Years ago, the Patient Advocate Foundation helped me in their copay relief program, pay for a medication for a couple years. It meant so much to me because just getting help with that one medication, it took a lot of pressure off of everything, like food bills, gas, all of that. The Patient Advocate Foundation is a sister organization of the National Patient Advocate Foundation. That support, it made a huge difference to me, as I just stated. At one point, due to my health, I was forced to stay off my feet for a couple months, having a bad foot fracture and 2 surgeries. But still wanting to do something meaningful, I became a volunteer for the National Patient Advocate Foundation and have since become and enjoyed being a volunteer. I share my story because I don't even want one patient or one family to go through this again or to feel alone. I don't want them to feel alone through this either. That there are resources out there to help them to bridge the gap. If sharing my story helps only one patient, one family, it's all worth it to me. It's all worth it. And thank you so much for listening to my story. Thank you.
Janet, thank
Sorry.
you. No, do not be sorry. Thank you. You're bringing tears to my eyes. Thank you so much for sharing your story. I know when we have spoken, you've talked about how last year was the worst year of your life, and yet you still want to give back so that others can't and won't go through what you've been through. So thank you again, and you're getting so much love from people in the chat. I want to turn it over now to Nicole, who in many ways we've invited her to speak here today because she herself, through her own lived experiences as a patient, as a award-winning board-certified patient advocate, as an author, Nicole has just this unique perspective in seeing and hearing what these impossible choices look like. And so, Nicole, would love for you to say a bit more of what you've seen and heard in the last couple of months from the clients that you and your team has helped. Go ahead, Nicole.
Sure. Thank you for having me. And before I dive into my piece, I just wanted to give Janet all of the flowers in the world, I think, for not only enduring the circumstances that she has, but to bring such a beautiful light and a giving servant attitude to that in the midst of all of this, to say, hey, I still want to give back. I still want to make sure that the next person doesn't have to go through what I went through. And in this work, in my opinion, you meet people at various different stages of processing what it means to navigate the healthcare system and all the emotions that come with that. And for you to still be so very much in it still and just want to pour back into it, it took me back, and I think everybody's there with it. So I just want to give you all of your flowers for that. It's just truly just beautiful. So thank you again for having me. In the last 6 months, 6 to 12 months, the conversation around affordability of healthcare and financial stress and toxicity relative to patients being able to afford their care, and the decisions that they planned to make maybe a year ago as opposed to their options now, has completely shifted. In the past, billing and how am I going to pay for this were always a concern, but it was more of a background concern as opposed to something that sits at the forefront of the conversations that we have. To the extent of that is the reason that many people even reach out to us, is because they receive a bill that they don't understand, or that was billed in a way that it wasn't supposed to, or insert every other issue and reason that comes with that. And even in the conversation about healthcare navigation and coordination, people are trying to grapple with the fact that the options that I had, or that I thought I was going to have, even if they were in a place of I'm okay financially before this, have drastically shifted. So now people are saying, well, I may not be able to age at home. I have to utilize these other avenues that are covered differently, or impact my cost sharing this way. And that does a lot to someone's mental state, their quality of life, and it's very difficult. And that's why I'm so blessed and so honored to have the opportunity and have the ability to work alongside so many people and patients that are smart and capable and motivated, but are just lost in some of these unforeseen moments in the healthcare system where they don't know how to navigate it. And now on top of that, they don't know how or if they can pay for it. So I'm looking forward to this conversation, and it's a great one to have.
Thank you so much, Nicole. And we look forward to hearing a lot more of your insights in a couple minutes when we have our panel discussion, and we will invite questions from the audience. At this time, I'm going to turn it over to Rebecca Kirch and Rebecca Angove to share a little bit more about the numbers behind the stories we've heard, some of the examples that we've heard from Janet and Nicole. And so just bear with me a second while I bring up the slides.
Thank you, Janet and Nicole, so much. The Rebecca and I are here in the room with great gratitude for the incredibly powerful testimonials and the discussion that we're going to have. And we told you earlier, and really do mean to treat this as a living room conversation, because that's what helps make what we're seeing real. There's been so much interest lately around affordability. And so Rebecca and I are each going to introduce ourselves as the entree into our conversation about what these healthcare cost concerns mean, and the motivation really behind our our work in research to put some statistics alongside the stories. I'm Rebecca Kirch of the National Patient Advocate Foundation. So I head up our policy development work and the grassroots advocacy that Melissa oversees. And we are, as Janet said so beautifully, as our grassroots volunteer, the sister organization or the advocacy affiliate of Patient Advocate Foundation that provides direct services to patients, including the copay relief program that Janet mentioned, having benefited from years ago, the charitable copay relief, and also case management, which helps people find their way to and through the types of resources they need to maintain their financial health. And I work and very honored to work closely with Rebecca Angove, who will introduce herself and the Patient Insight Institute.
Hello, everybody. We got the slides figured out, so that's the good news. It's not a webinar unless there's a tech glitch, right? So yes, I am the other Rebecca, Rebecca Angove. I am with Patient Advocate Foundation's Patient Insight Institute. We partner or work closely with NPAF, we're sister organizations, and our work is really around focusing on gathering patient insights, both in a more formal and structured data way through surveys and other listening sessions, focus groups, qualitative methodology, but really to make sure that the patient voice is integrated and infused in everything across the healthcare ecosystem. Particularly for this presentation, we work closely with NPAF. And we also do a lot of work with the patient engagement piece, so making sure that patients' voices and insights are not only included, but patients themselves are really centered in all the work that we do. So that's a little bit about our Patient Insight Institute. You'll know what it is when you see it and hear it, and we get to present some of the data, the insights that is really the backbone of the stories you just heard, right? And that data shows that those stories are not isolated incidences. Those are not just, cherry-picked, experiences of the few, but those are just a couple stories that many patients are currently experiencing. And that's the point of the data. It's not to dehumanize. It's actually to show the depth of the challenges and the experiences that patients are having, that it's not just a couple, it's many of us across the United States.
Hey, thanks, Rebecca. And I'll say there's been some releases of polling data recently around, Americans' responses to the affordability challenges they're facing. And it struck me when I saw the statistic that healthcare represents nearly 1 in every $5 spent in the U.S. economy right now. That's ginormous, not comparable to any other country in terms of the spend. And we've been seeing a great deal of energy and emphasis, just like the stories that we heard from Nicole and Janet, around how much healthcare costs, combined with daily living cost increases, are affecting people. I wanted to kind of kick off our conversation with this aha moment slide for all of us that inspired the work that we're doing. It was sort of kick in the backside to realize that people are so concerned about their financial health that they rank it above dying. And Rebecca, this is your data from Patient Insight Institute's survey work last year. But talk a little bit about what this means for you, and in the context of the stories we just heard from Janet and the aggregate stories from what Nicole described.
Yeah, it may or may not be surprising to those of you on the call, but when we asked patients what their top concern was when it came to healthcare, their treatment, their diagnosis, it was overwhelming that concern around the financial impact was number one. It was a bigger concern than long and short-term side effects, the possibility of dying, right? They it really was about not just, can I afford this care, but also what am I going to have to do to afford this care, and what kind of a situation is that going to put me in? And what we see is patients thinking about those pieces, thinking about leaving their family bankrupt, thinking about having to sell their house or sell their car or make other cost of living adjustments before they even enter into treatment discussions and make treatment decisions. So this isn't something that they, follow the recommended course of treatment and then say, oh, I should worry about the financial stuff on the other end. They're actually actively, before even, at diagnosis, before even entering into financial conversations, and during these treatment decision making conversations, financial wellness is a top concern that is driving and influencing the decisions they're making around their care.
And we're going to dive into that more specifically. But before we get there, because I read up on some of the polls coming across for all Americans, so these aren't unique to patients like our research is, where we're asking a patient population. But there are a couple points that I think are important to highlight, including that the population that you survey, what is it made up of in terms of insured, in terms of resources? What's our typical demographic for the research you?
It's a great question. So we tend to be diverse in all the ways that you can measure diversity. We are geographically diverse, race and ethnicity, even a fair amount of diversity in our SES, socioeconomic status, income, education, things like that, because we serve a wide range of patients across the United States with a lot of different diagnoses. What's unique about our population is that they all have a chronic or complex illness, so they are actively navigating the healthcare system in a very intense way, a lot of them, and they all have a history of access and or affordability challenges, which just means that they have reached out to PAF to ask for help, either in affording their care or navigating the larger system. But that really, when you look at the demographics of who those patients are, patients and caregivers, it is a wide range of people, and it's likely some people on our call. It's your neighbors, it's your friends. This is not a tiny group of people that are just like those people, right? We are all struggling with access and affordability challenges right now.
And that tracks so well with what we've seen from the KFF polling and even an earlier Gallup poll around open enrollment time, which is where we did our survey work too, that we're going to feature next. But this is folks who have insurance. This is middle income folks, not just those who are on the lower income side of the sphere that are struggling. And it's ranking as the top concern among Americans, let alone those who are patients or caregivers.
Yeah, and Rebecca, these are primarily insured patients either through Medicare, Medicaid, or private employer-sponsored insurance. So these are people who should, I'm going to air quote there, right? But these are people that really felt because they had insurance, they should be able to afford care, right? We think those are the protected patients, and what we're finding out is that they really, really aren't.
So these trade-offs are real. Let's take a look at the next slide, Melissa. So, and Rebecca, maybe you can talk a little bit about the inspiration behind the survey work we did more recently as a follow-up to the data you just shared.
Yeah, so we decided to really, with NPAF, we decided to really dig into what does this financial distress look like, and what is the real impact of it, right? What are people really seeing changes in their healthcare cost? Are they worried about seeing changes? And what are they doing in response to those changes? So that is where we started when we decided to do this survey. And what we found, again, probably not surprising to many of you, is that they are still reporting cost as a top healthcare concern, right? Over half, when we asked what is your biggest concern when it comes to healthcare, it wasn't access, it wasn't treatment, it was cost. So that's still top of mind. That number grows if you look at those that listed it, among their top 3 or their top 5 even. And then we noticed that they are our patients, the patients we surveyed, are seeing an increase in healthcare costs. So it's not just that they're worried about it, they're actually seeing these costs going up. Everything from insurance, prescription costs at the pharmacy, and also the costs that they're paying out of pocket for care. So these are real trends that have been reported in other surveys and other polls, but we replicated it here with our population.
So grateful to see people
Yeah.
introducing themselves in the chat, and we didn't give that prompt for folks to do, so I'm so glad from other policy consortia we always do that. So please do introduce yourselves in the chat as we keep going. And Rebecca, I know you had another point you just wanted to make. Go ahead.
Yeah, and it's little, it's tiny on this screen, but this survey is a pretty robust survey. It's almost 1,000 patients. I think this one had 970. So this is not just, a couple 20, 25 people. This is, across the patients that we serve across the United States. We got about almost 1,000 people to complete this survey.
In a really rapid response, short bit of time that the survey was fielded. I think that shows the robustness of the response shows the urgency that people are feeling around their healthcare costs and what that means for the trade-offs that they make.
Yeah. And I think they're hopeful that by doing these surveys, by sharing their stories, their experiences, that we can find some solutions. So that's, actionable research, right? We're not doing this just to show the problem. We're showing there is a problem and let's figure out what we can do.
That's so key, because research for research's sake is not how we roll. We certainly want to make all of the stories, all of the evidence point towards solutions that are meaningful. And we'll talk a bit about that in the context of needs navigation. But we have another slide about some more findings you had. We can pull up, Melissa.
Yeah, so when we did this survey, we wanted to know exactly how people's lives, kind of their healthcare landscape was changing, directly related to cost. And we found that 43% of the people that filled out our survey said that there was a change in their coverage in the past 3 months. And some of that was optional because they needed a different insurance product. Some of that was changes in eligibility for maybe Medicare, Medicaid. Some of that was changes in their employment. But that's a big disruption. 43% having changes in their coverage. And the other, on the right side of your screen is the impact of this cost increase that I'm talking about. That was kind of shown on the previous slide. And some people did change their insurance coverage because of costs. They needed either a lower monthly payment or their insurance product was not adequately covering their monthly expenses, and they had to make some changes. But we also see changes that people are making that is a little more detrimental to health and care. And these are really hard decisions that people are having to make due to cost. Skipping or delaying medication, right? Like I'm just going to skip a dose because now I can get, 60 pills. I can stretch that out into 2.5 months, or they're just stopping medication altogether, right? I can't afford this. I need to eat. I need to pay my rent. This medication is just unaffordable. You saw the cutting back in insurance coverage statistic, and then the delay in care. Just not going to the doctor, pushing off an appointment, not wanting to pay that copay. And we also have found that some of this cost fear, is also creating hesitation. So they're not actively pursuing care, even, screening or recommended care or treatment, because they're just scared they can't afford it. And they don't want that stigma, that bias. They don't even want to step into the office and to be turned away. So there are a lot of behavioral impacts, life impacts that are happening because people can't afford care. It's not just that a bigger bill comes in the mail after you get care. There are things that are really limiting people's health and well-being.
Thank you, Rebecca. And I think we dropped in the chat the Gallup poll that was published earlier this week, or on the 12th. That might be last week, but pretty ripe, ready info about that Americans broadly, not not exclusive to patients, are saying that their healthcare experiences are affecting. It influences all sorts of long-term planning that they have, major life decisions, right? So this tracks from the patient perspective around specific to their healthcare, but that's also in the swirl of everything else in terms of daily living expenses and making trade-offs across the board, like Janet and her husband, who had the very difficult decision of, we need to sell our house to be able to pay for what we need to stay as well as possible.
And just something to add to that, what we find, we've done a lot of surveys, and this was a much bigger survey than just the few data points I've shown. But those stories are varied, and everybody's finding different ways to cope, right? We tend to see two camps of patients that are doing everything they can to afford care. So they are selling their house, they are getting rid of their car, they are, skipping meals. Things that they're really affecting how they are managing or spending their, kind of their life dollars in order to afford care. And then the other half, and it is about half when you look at the data, they are foregoing care to pay their rent, to buy groceries for their children, to do all of those other cost of living pieces. And so just because somebody doesn't report that they're skipping or delaying medication or, cutting back on care, they're likely doing some of those other activities that are still limiting their health, their well-being, their family life. So that's kind of the divide that we see. People are really forced into this hard, nearly impossible choice of, do I spend the money getting the healthcare I need, or do I spend the money on things that I need to live, food, shelter, and that's an impossible choice for many of our patients.
We can go to the next slide, and I want to dive a little bit into solutions and then bring our panel discussion into the fold so that Janet and Nicole can join us. But one of the areas that National Patient Advocate Foundation has focused on as sort of a signature move in this solutions-oriented space is calling on experience of our Patient Advocate Foundation's case management efforts, community, health center workers, social workers, all the different positions out there in different healthcare settings, patient navigation, financial navigators who are focused on recognizing, as Melissa said up front, that financial, mental, and medical health are all entwined. And we need to think about the opportunities where we have to advance practical solutions in every kind of healthcare setting. So I feature here our definition of needs navigation that was developed with patients and caregivers through the Patient Insight Institute's focus group and cognitive testing work. Needs navigation is the solution that we're advancing. It's not the be-all, end-all only solution, but it's a key one that we know is important to help people feel heard and understood about financial health being a priority right alongside their mental health and their medical health. And our definition is that it provides hands-on support, and that means real person-to-person, helping people find and use resources to ease their cost concerns. So we have an issue brief and some other information that we'll drop in the chat that's available for folks to learn a little bit more and share their stories as well. And Melissa will talk about that a little bit later in this session. But if we go to the next slide, I just want to wrap our piece with two additional little bits, including the opportunity that we see to bring needs navigation into every care setting, focused on financial health right alongside the other aspects of health that are entangled in people. We want all three. What's important for us to emphasize here, I think, as we talk about solutions, is the opportunity for policy levers to raise awareness, understanding, but also operability in every kind of care setting for what patients, caregivers, and healthcare practitioners are demanding to deal with financial health alongside these other aspects so that people can feel whole. And the importance of integrating needs navigation as an intervention for financial health in all the different care settings, whether it's inpatient hospital care, skilled nursing facilities, outpatient office visits. People need to have their financial concerns asked about and addressed as a normal part of the healthcare process now. And that's what we're trying to advance as an advocacy agenda. And we're working with entities like CMS that pays for Medicare and Medicaid in the states, the opportunities where we can anticipate only growing cost concerns as the health policy changes keep happening, and how we can collectively work together for advocating that financial health needs to be prioritized part of health system reform. So that's sort of a little bit of a soapbox session before we invite our panel back. And I'll conclude with this, and I'm excited to hear feedback from our panelists about some of the words that we use that can be othering or stigmatizing or helpful. And Rebecca and I often talk as we're thinking about research about what's the messaging that matters to help people understand and feel confident in speaking up for what they need. And there are many words and jargony things that swirl about. We featured some here, even value or value-based care. These are words that are used all the time in policy as if it's commonplace, but really diving deep into some of these terms like safety net, care model, even social services and financial health, we need to dig deeper with all of you in our audience, but also our patient caregiver network to learn a bit more about how we can associate these words to have real resonance and meaning for people. Rebecca, can you say just a little bit about the messaging work that we're planning to do before we invite Nicole and Janet to join our conversation?
Yeah, absolutely, Rebecca. So, you teed this up so nicely. It is essential that the words that we, and when I say we, everybody, the whole ecosystem, from the work that we're doing as research and advocacy organizations, as direct service organizations, as well as, the payers, the healthcare system, everybody, we use words all the time that have little meaning or confusing meaning to patients. And we as NPAF and the Patient Insight Institute, we know that there is a bridge that needs to be crossed, a little bit of translation that needs to be done. And so what we're really trying to do with a little bit of qualitative research is to do some term testing, some cognitive testing, which is just a really fancy way of saying, we're going to talk to patients and figure out, how do you feel about these terms? What do they mean to you? And then we're going to talk to those people using the terms and tell them, hey, you need to maybe adjust your language, or when you're using these terms, define it in a way that feels meaningful to patients. Because a lot of people are just using these big, buzzy words, and there's not really coordinated and consolidated meaning behind them. So we're going to be doing that. We might even reach out to some of you to be part of that work. But I think at the heart of all this is communicating, right? We all have to be using the same language. We have to understand what we all mean when we speak. And it's not about teaching patients and making them, figure out the system. It's really about doing that translation, helping the system use words or use them in a way that's meaningful to patients, and then also helping patients to better understand what some of these buzzwords are. So that's the work that we're going to be trying to do. Probably in the next quarter, next few months. We'll be starting it next month, and then it'll take us a little time. Hopefully, in time for next Policy Consortium, I will be back.
That's our aim, absolutely. And I'll invite everybody. I'll invite our Janet and Nicole back into the room, the living room, if you will. And I'll also invite all of our participants in this Policy Consortium. If there are, you saw the words that we've identified as our initial run, but if there are pain point words for you or phrases, do drop them in the chat so that we have a robust list of the types of things that we need to dive into to help round out this research with a patient-driven focus. Janet and Nicole, welcome back. You've heard a little bit about the research that Rebecca and I just talked about. Were there any surprises, Janet, for you in seeing these numbers, or what jumped out at you about what you saw compared to the experience you had?
My experience has been, but to think that people are more worried about their health than death. I mean, that just says it all. That's just amazing to me, that statistic. It's, I know what I was going through, but to hear that, in a way, it doesn't surprise me at all. It does, but it doesn't. How Americans are so concerned.
Nicole, what's stuck out for you, given the many patients and family members that you're helping every day? What stuck out for you as resonant or particularly concerning?
Sure. For me, just to see I think the dichotomy of just how many people in this very large study are saying, this is my, like, this financial component of it is my primary concern for the most part. Because with the work that you do, you have an understanding, you have visibility. You're looking at the people that you're talking about, and you're able to draw those parallels and start to identify many of those patterns. But to have the opportunity to look at oh my goodness, this really is as or so far as say as bad as you think that it is, really does make a difference. And to draw on that point even further, when we talk about the position that affordability or just being able to pay for your care has in your position to, can you all hear me?
We can. You were breaking up a little earlier,
Sorry,
but now you're good.
Oh, good. Okay, because something's frozen. I can't see much, but I'm here. But ultimately, like, to look at that position of now, before I can make a decision about what is best for my health, I have to really take a hard look about how I can afford it. And that truly in and of itself is heartbreaking to be able to say, especially if we look at populations of patients that have complex illnesses, chronic illnesses, conditions that may worsen with time if not treated effectively, that now when they have the opportunity to, and that's going to work for them, they necessarily dive into that. They can't necessarily dive into that and say, this is what I want to do unequivocally to anything else. It's now, how am I going to pay for it? And if I can't pay for it, how long can I put this off for before it becomes an illness? And what we know from data even moving forward is that as you delay care, as patients delay care, the probability of them becoming more ill or sicker without the medication, without the treatment, just continues to snowball, and ultimately they become more expensive patients to treat. So the cycle just continues, and that's what just makes it worse. So those were my thoughts. I think that it's great to be able to see the data on the screen and put some fact, for quote unquote a better term, to it, so that people don't just feel like this is a conversation of, well, this is how I feel in my corner, in my pocket. That no, this is an actual issue, and this is the percentage, the population of people that are experiencing it, and that it spans, like you said, not just people that are lower income or making or on a fixed income, but even people that we're seeing that may be quote unquote comfortable, but now they're realizing that they have to really lean into that nest egg or that savings that they may not have had to in another place in time, which ultimately is not a infinite bucket of money, resources, etc.
Yeah, Nicole, depending on where you sit, it's probably either validating that you're not the only one, or shocking that this is happening, or both,
Yes.
right?
Mm-hmm.
I think for a lot of people, this is not surprising, but then I think there's a whole nother group of people that are just learning this is happening across, a wide group of patients, and increasingly, like you said, not just defined by a certain income or a certain insurance type. Absolutely. And projects like this, we want to amplify that, so the people making the decisions know what's going on with patients.
Absolutely. 100%.
And Janet mentioned too, it's not a matter of, okay, we sold the house to do the right thing, which is be able to afford our health insurance coverage. And I know many people. And then, Janet, you also mentioned the challenge of prior authorizations, which are sort of another area of difficulty in terms of having access. So even if you're paying your premium, that doesn't necessarily mean you're being covered for what you're paying for. And what has that experience been like for you? And what would make a difference for you in terms of being able to ease some of that dual pressure?
I mean, this year the prior authorizations have been really, so you need it for everything that maybe a couple of years ago you didn't need it for. And it's just, and then the prior authorization, you put it through and they deny it. And then you try it, your doctor puts it through again and they deny it again. You can appeal it, but still, so you just sort of give up on it. I mean, I think if there's any way to, how to deal with your insurance company if you do experience denial with prior authorization, some guidance, maybe a way to appeal it, guidance on appealing it better, the process. I think that's it.
Yeah. And Nicole, that's a big part of probably what your role is for people, right? So you are that needs navigator that we're talking about in your own right, and you have some skills developed from years ago in this financial health space alongside helping people with the clinical complexity of things. Can you tell us a little bit about what that's been like for you and what it means to people when you're there as that hands-on support?
Sure, absolutely. The navigational component of healthcare means so much more than I think people initially believe that it does until they're in a situation where they realize, outside of the fact that they are overall like competent, they know how to ask questions or who within the system they can sort of kind of go to. You're faced with a situation at one point or another where it's like they hit a brick wall of, I don't know how to navigate this or how to deal with it. And for me, my experience is a bit multifaceted, I think, like many advocates. But for me, having been a patient that was misdiagnosed a numerous amount of times, to then have taken that experience and ran, I think, into the burning building to understand how healthcare worked from the inside. So working in healthcare administration, in public health and systems like large academic medical centers like the Cleveland Clinic, working with payers and things like that to know what that scaffolding looks like from the inside, as well as a board certified patient advocate, an independent entity that has I think the flexibility and the freedom to be able to weave between those spaces as is seen fit. You realize that there's things that you don't know. And for example, we'll have clients that may have this big scary bill and they'll come in and, their main goal is to be able to financially figure out how to deal with this or to negotiate it down or whatever their issue may be. And then they work with a professional and it's like, oh my gosh, well, when I did the appeal or when I did the whatever, it didn't go through. How did you get this to go through? And that is, I think that's the value that is presented with a professional, with a needs navigator. And there's individuals like me and obviously like the programs at NPAF where you have these amazing people that know how to do that. And so that actually means a lot in my experience as well. It means a lot to a person's ability to safeguard their confidence and their resilience in the system, because ultimately, if you're continuing to move through a system where you feel like you're making a wrong turn every 10 seconds, that you're doing what you said you were, like you're doing what someone said that you were supposed to do, you did it, it didn't work out, and you're going through this rigmarole, at a certain point, you have people that will throw their hands up and say, well, you know what, I'll just figure out how to pay the bill, or I'll figure out how to do this, that, and the third. And then you're making decisions. And some people ultimately, like, that's a decision that they have to make for one reason or another, but they're not empowered in a way to be able to have all of the correct cards on the table to make the decision that works best for them. And in this situation, specifically in this conversation, we're talking about financially. So what things are available to me? You know, am I eligible for charity care? Can this be negotiated? Do I have to be? All of these other questions, navigators can help answer those, and specifically like independent patient advocates and other patient advocate adjacent people as well, can help answer those questions that can completely change the quality of life I think that patients have with the system and their ability and their resilience in navigating it.
And I just want to lift a couple things up from the chat, because Nicole, I think the chat's been kind of tracking exactly where you're going. There's a lot of chatter in the chat, which is fantastic. I love it, about how important it is to have an advocate or to have somebody that's helping navigate, that is looking for what's best for the patient, right? Not that's what's best for the insurance company, not that is what is best for the healthcare organization. And so there's a lot of chat really circling around this idea that if we just do what patients need, that's really what patients want to see in healthcare, right? Not trying to, worry about corporate bottom lines or for-profit healthcare or making insurance companies profitable. And so there's a lot of chat around there. And I think that's a good point. I think that's central to what you were just saying. The other piece that I don't want it to get lost, I think it's really interesting, and we did actually grab some data around this too, but when patients are diagnosed with a complex or chronic illness, it can often impact their ability to work. So this idea of the compounding financial stress of having all of these bills, plus now I have to use all my PTO, or maybe I don't have PTO, maybe I'm going to lose my job because I can't go to work, I have to reduce my hours, right? There's a lot of ripple effect around employment, and a lot of insurance is tightly tied to employment. So I just want to add kind of that extra layer, which we didn't get into in the data, but it's a really important point that kind of came up in the chat. So you can tell my eyes have been looking to the side, reading every thing that's going on over there.
And Melissa's here to help guide this piece about some of the questions or comments from the chat that we want to make sure we call out before we close.
Yeah, we actually have some questions that came through in our question and answer box, and encourage other questions if you all have them. I know the chat has definitely been lively. But this question from Shilpa, how do you get trained as a needs navigator? Who wants to take
So there are a
that
number
one?
of ways, but Nicole, you may have the best answer here because you have financial navigation training in your background.
Sure. My experience is one of many, and I'm sure as other people take their take on this question, you'll see other paths to doing it. For me, especially in financial needs navigation and everything like that, my first experiences started in corporate. So within the healthcare system, I was a financial counselor. So I learned coordination of benefits. You learned all of the more nuanced information about how insurance, what should be covered, what present, all of these questions to ask, which came from that formal training there, which was looking back at it, I think it was a really great opportunity. It just kind of presented itself, and it was a part of the foundation for what I would further go on to do. But then on top of that, I became a board certified patient advocate, and many board certified patient advocates, I think that we're a wonderful group of professionals, and every advocate that I've met has had different emphases or different specializations in what they do and how they help their clients. So there's some people, even down to specific diseases, some people that just work with, for example, affording care as a cancer patient, or affording care at end of life and things like that, or where I started in the communication and just overall navigation component of it as well. So the next part about this path is I truly don't believe that there is a right way to get there. I've met many people who have fallen in love with this work and said that they wanted to be a navigator because they had a specific brush with it in their personal life. Maybe they had a loved one that was ill, or they became ill, or they found themselves navigating care for a child or someone else. And then at that point, they continue to gain and acquire these skills, and at least just information of how is the process supposed to work. And even in the work that I do now, where I have my practice and we support clients from various different walks of life and everything that they do, there are still advocates that I know, like, for example, someone that maybe very specialized in lupus, and you have someone that would love to work with someone that actually has a lived experience with lupus, or how to ask questions about medications and things like that, and you find those people. So hopefully that's not too much of a roundabout answer, but that's a little bit about my path, and just an encouragement that from whatever walk of life you come from with it, if you do have an interest or a pull towards it, that you should follow that, and just learn as much as you can in your specific niche, or generally as well, if that's what you want to do. And there's definitely there's a need for every walk of life out here. Definitely.
There's definitely be a higher and higher need for people who have experience with navigating the financial health aspects, just as we now have established patient navigators that help through the clinical complexities of, especially in cancer. That's where I'm most familiar with patient navigation, and helping patients find their way to and through their screening, diagnosis, survivorship, etc. And there are insurance navigators. So there are different kinds of navigation because the complexity of the system is so very real. And we know that there's some who are very highly trained, as I mentioned earlier, in community health centers. They work with under-resourced patients already and have learned to be very scrappy with financial navigation. We can learn so much from how community health workers operate, from how in inpatient settings and even skilled nursing facility settings, the social workers that are responsible for helping guide people through their financial challenges with their loved ones. So there are a number of different people in the different care settings who are skilled. There isn't a traditional yet certification program, but that's of course what we want to strive for as we think about what should the care model look like that is integrated into every piece of the health system, that's honored with appropriate investment from the health systems, from the health insurers, but is trusted by patients. As Rebecca highlighted, this needs to be a peered process of trust to make sure that they're focused on the patient and caregiver's best interests, not the bottom line of the companies. Another question, Melissa? We have time for another?
Yes, we have time for one more, and many thanks for answering that question. This is from Amber, and this is regarding the question around prior auth, or the discussion around prior auth earlier. Many patients still face delays due to prior authorization and payer requirements. What policy changes or advocacy efforts are most effective right now in improving timely access to, this says cancer treatments, but I'm sure it applies to any diagnosis?
Prior authorization is the sister of financial health concerns, as we talked about, in terms of the challenges that we face. And there's a great deal of regulatory work trying to make prior authorization more streamlined. And the challenges that we've all talked about here, Rebecca, you may want to weigh in on this in terms of what you've seen with the data people have, but anything that stops access from being efficient is a cost, not just for people, but for the health system. And so there are policy initiatives in the construct of trying to create opportunities even for artificial intelligence to do a more efficient, streamlined job. So I'm not able to point out a specific, I wish there were a bill that would sweep it all away. There is not. But there are many different conversations happening in policy circles to try to make efficiency happen so that it actually clears the deck for people to get access instead of creates a barrier. We know that balance is not rightly set. Janet, you talked about it very directly. I've experienced it. We probably all have with family members and ourselves. But there's a great deal of momentum toward showing how we can streamline the processes, eliminate the burdens to get the right people to the right care while we're not doing, because it's a huge headache for the practitioners as well, who are stuck on the phone instead of seeing patients.
Yeah, I would add, I know we're really close on time, but I would add that yes, prior auth is a huge cost, time, burden that delays care, that causes a lot of headaches all around. And those delays in care, as Nicole mentioned earlier, often costs health, right? And wellness. So those delays are important. You mentioned AI, Rebecca. I saw Sarah in the chat. Yes, we are looking at some AI because the AI might increase efficiency, but it is not necessarily making the right choices. And so, you can't trade off efficiency for poor decision making. And so there's a lot that needs to be worked out. That's a whole nother hour conversation. So I'll stop there so we can get to next steps, but to be continued.
All right. Well, I know we are at time. I just have a couple quick things just to go through real fast. Just some next steps from us. And before I even dive into the next steps, I will be remiss if I do not pause to thank Janet and Nicole and Rebecca. And Rebecca, thank you for this wonderful discussion, this very timely and important discussion. I always struggle to keep up with the chat, but I think this really resonated for so many of the people here. But Janet, especially your courage to come on today to share what you have gone through, your family has gone through. Thank you so much. We are deeply, deeply grateful that that we can count you as one of ours. So thank you, Janet.
Yeah.
Some next steps is that we are going to work on getting the recording accessible as well as sharing the issue briefs. I believe members of my team have put links to the issue briefs in the chat, as well as a data brief from Patient Insight Institute that goes into a deeper dive about the survey work that was done. And then I know a lot of you contributed to the chat regarding what are these terms that you're hearing and that you think should be part of this term testing that should happen. I think I saw some terms around social determinants of health, financial toxicity. I know that's something that we have done already. So we're going to dig a little deeper into what that looks like and translate that to action steps for us. And we want to continue to use these real world stories to make that imprint, whether it's working through regulatory agencies or with people on Capitol Hill, to have them understand that this is what patients are experiencing right now. And we really cannot do any of that unless we actually have your stories. And so a couple slides down, we have a QR code that we invite you to use to share your story. I'll talk a little bit about that. But we also just encourage you to, in terms of your next steps, once this meeting is done, we have an evaluation for you to complete, and to please share if you joined our network, if this meeting was forwarded to you, to just please sign up for our email so that we can include you in our midst as well. If you enjoyed this conversation, we will be having others this year. Our next one is going to be in June. And after that, September and then November, we will email you to get those registrations. So no worries, just wanting to make sure that you can save these dates. And last but not least, here's the QR code so that you can share your story with us. As an advocacy organization, you all know the importance of capturing stories, telling stories. And I think you can see in terms of what we did today with Janet's story, and even in bringing in someone like Nicole, we use your stories to bring that humanity to the data that our colleagues at Patient Insight Institute gather. And then we elevate those stories so that people who are making these critical decisions about how people experience healthcare hear them as well. And so we'll leave this slide up for a couple minutes just so that you have a chance to grab that QR code. But we want to thank you again for spending time with us. And thank you so much. We look forward to the next conversation. Take good care.